Συνεχίζουμε με το δεύτερο μέρος της ημερίδας μας, στο Προεδρείο ο Δ. Άδωνης Ιωαννίδης και η Δ. Χλώη Αντωνίου. Η Δ. Χλώη Αντωνίου είναι αναπληρώτρια καθηγήτρια βιοχημίας και συνδιευθύντρια του μεταπτυχιακού προγράμματος μεταπτυχιακών σπουδών στην Ιατρική Σχολή του Πανεπιστημίου Λευκωσίας. Κατέχει διδακτορικό στη χημεία από το Πανεπιστήμιο του Ιλινόης στο Σικάγο. Επίσης, έχει μεταδιδακτορική της εκπαίδευση στο τμήμα βιοχημίας και μοριακής βιοφυσικής του Πανεπιστημίου του Σικάγο. Τα ερευνητικά της ενδιαφέροντα είναι η πρωτεϊνική βιοχημία και η ιατρική εκπαίδευση. Ο Δ. Άδωνης Ιωαννίδης είναι κοσμήτωρας της Ιατρικής Σχολής του Πανεπιστημίου Λευκωσία και επιστοποιήθηκε από την Ιατρική Σχολή του Πανεπιστημίου του Μάντσεστερ με αρίστα και πήρε διδακτορικό στην αναπτυξιακή βιολογία από το University College of London.
Allow me to switch to English. It is with great pleasure that we welcome Professor Nikolas to today's conference. Dr. Boy is currently a consultant in pediatric metabolic medicine and child neurology at the University Children's Hospital in Heidelberg. Following his specialization in pediatrics, his main scientific activities focused on metabolic medicine and specifically Glutaric Aciduria Type I. He has been the coordinator for the guideline group for Glutaric Aciduria Type I since 2015 and has coordinated 2 guideline revisions since then. In 2023, he has been appointed as Professor of Pediatrics in the Medical Faculty of the University of Heidelberg. His current research interests lie in the long-term outcome and disease variants of Glutaric Aciduria Type I and other organic acidurias, as well as urea cycle defects and mitochondrial disorders. The title of Professor Boy's lecture today is Revised Recommendations for the Management of Glutaric Aciduria Type I and the Transition from Childhood to Adulthood Monitoring. Professor Boy, the floor is yours.
Thank you very much for a very kind introduction. Hello, dear colleagues, dear families, dear patients, dear students, anyone who's involved in metabolic disorders, interested in the field. Thank you very much. Thank you, Marias, for the invitation. It is a great pleasure to be here again. I have been invited to recent conferences also, and it's a great pleasure to be here again. Before I start, I would like to know, new GA1, or better, who did not know about GA1 before this very day? Everyone knows about GA1. Very good. Okay, one didn't know about it. So great. So it's good because I chose just a very, very brief introduction about GA1, and then I go directly into the revised recommendations, and I try to show you why the recommendations are as we formulated them, and also some of the scientific background. So, I promise this is the only pathway. You have seen it before. It's the lysin pathway. So you see that it's located in different parts of the cell, in the mitochondrium, in the peroxisome, also in the cytosol. And still, there is a little debate today how it actually works up to the very front. Really? So you don't see the light, right? It's okay. Okay. So the question of debate today is still this very upper part of the lysin pathway, but we definitely know is where the enzymatic block in GA1 is. It's down there and it's highlighted in red. So the glutaryl-CoA hydrogenase is insufficiently active, and this results in accumulation of glutaryl-CoA, and this is then metabolized to glutarylcarnitin, which is used for newborn screening, and on the other side, the production of glutaric acid, 3-hydroxyglutaric acid, what gave the disease its name. It was described in the mid of the 70s by Stephen Goodman that you see at the very left front. So depending on the residual enzyme activity, there are 2 biochemical subtypes that are actually separated from each other, the high excretors and the low excretors, which I'm going to talk a little bit about today. So why is this disease such a devastating disease? You can see here the two main clinical manifestations. On the left-hand side, you see the acute encephalopathic crisis. You have heard about it before. So you see a brain where the basal ganglia structures, deep gray structures within the brain that are very important for coordinating motor activity, but also for other things, are completely destructed. This results in very severe dystonic movement disorder, increased mortality and increased morbidity, of course. And then on the other side, you see a milder manifestation of striatal injury. It's called insidious onset. So it's patients that not suffer from an acute encephalopathic crisis due to febrile infections, but they show a very slow deterioration, a slow worsening of their motor function. And also the defect, the lesion in the striatum is milder. You can see it's located at the very back of the striatum. Both forms have in common that they manifest within the first 6 years of life, and they are irreversible, so they have a very high prognostic clinical relevance, of course, for the patient. So the aim of all our treatment efforts is really to prevent this manifestation from happening. Beside striatal injury, in the recent years there has also been many descriptions on extrastriatal abnormalities, so abnormalities in the brain outside of the basal ganglia, and we have various ones. On the left-hand side you see the frontotemporal hypoplasia, which is very, very characteristic for the disease, but it can be very dynamic. So we observe this in very early diagnosed patients, even newborn screening patients, and then once we treat them, and this is one patient followed over several years, then in the very end you see a complete normalization. Furthermore, we observe white matter abnormalities in patients. We observe subappendular nodules, so it's little nodules here at the roof of the ventricles within the brain. They start to develop about the age of 10 years, and they also observed primarily in high excretors, as all these abnormalities are primarily observed in the high excreting patients. But again, these changes are very dynamic, and some of them are reversible, some of them are progredient, and it's still under investigation what they actually really mean. So just to summarize a little bit the history of the guideline for GM1. So back in 2007, on the very left side, there was the first publication of the guideline, and since then you see we have 3 revisions already. And in the very first guideline, they really asked very, very basic questions. Is this at all a treatable disease? Is it really worth to implement the disease in the newborn screening? There were many people who said it doesn't make any sense to include this disease in the newborn screening panel. Also, emergency treatment, what kind of dietary approach should we follow? So very, very basic questions in combination with a very low level of evidence. So there were only a very few studies available, and this resulted that you see highlighted in yellow the very bottom, and the very weak levels of recommendations. So most of the recommendations were very, very weak in their level. But then following the different revisions and the following years, we had many studies, prospective studies, clinical studies that tried to answer very, very basic and important questions, and they helped us to improve level of evidence. So it became more and more evident that we have very effective measures for this disease, and also we were able to really improve the level of recommendations continuously, and we ended up in quite a good level of recommendations for the just finished recent revision. So this is hopefully the only little bit boring slide of the presentation, because it's about methodology. Just to show you that a guideline process is not easy, it takes a lot of time. In this specific case, we tried really to use a new method for guideline development. It's called GRADE method. It's shown here, and it basically means that the guideline panel first defines relevant parameters, relevant outcome variables, clinical variables that are actually important for patients, important for the disease. And then you screen the literature, you can then modify a little bit the assessment of the evidence that you find, and then you can come up with a formulation of recommendation. And then very important, the evidence is not everything. So GRADE allows us to use further criteria to really formulate a strength of a recommendation. So also the quality of evidence is important, but also benefits of harms and benefits, the values and preferences of the patient, but also social, legal or economical considerations. So all these come together and you have to assess each one of them, and then you actually come up with a grading of the recommendation. This all by 24 representatives. We had 13 professional societies taking or participating in this revision process. We had the patient support group participating. We formed working groups, many meetings, and a standardized process afterwards. And we are happy that we actually finalized everything now. So what's new in the recent revision? We have increased level of evidence that newborn screening and treatment are the most important factors in this disease. That is very, very important. We modified, specified most of the recommendations, and we also implemented new recommendations on arginine, on MRI monitoring, transition, and I'm going to show you in a second all the details. So let's start with diagnostics. We have heard a lot about newborn screening, and we still are going to hear a lot about it, so I'm very excited that maybe this table will hopefully change very soon. So you see here all the countries in Europe or European Union countries or candidate countries, and you see the different diseases, and you see that many screen for GA1, it's 24, the number at the moment, but many do not screen. And here Cyprus is still one of the countries who is not screening, and we hope that it will change soon, of course. This is the proposed diagnostic algorithm. So it starts with newborn screening, but of course it also can start with a targeted workup, as you can see highlighted at the side. So abnormal newborn screening results result in a biochemical confirmation. You examine the urine for glutaric acid, 3-hydroxyglutaric acid. If it's elevated, you start treatment, you confirm genetically. In unclear cases, you would also do enzyme activity testing, which at the moment only can be done at 2 laboratories in Europe. But of course, also, especially of course for a country without newborn screening, the suggestive clinical and MRI signs also can lead to the diagnostic workup of GA1. So this is also still important, and this is mainly the neurological manifestation or a macrocephaly, typical MRI signs that we can observe in patients, but also very recently we found that another quite characteristic cerebral manifestation is existing for GA1 patients is the subdural hematoma. So these are all MRIs from newborn screening patients. We examined over 50 of them, and we found in 8 of them we found actually subdural hematoma, and only 2 suffered from a head trauma. And before that, head traumas were the main reasons for GA1 patients to be reported to result in a hematoma. But we actually found that even in patients who did not suffer from a trauma, who did not show any symptoms, they develop asymptomatic hematomas. You can see them at the front. I hope you see them. We have white arrows highlighting the hematomas. And in the patients that we had follow-ups, they were resolving in all the patients. They did not lead to any symptoms, only observed within the first 3 years of life. And what is also very important is that they were not isolated. They were always accompanied by very characteristic changes. And if you remember the slide that I showed you about the extrastriatal manifestations, the frontotemporal hypoplasia, the white matter abnormalities, and also others, they are all existing in these patients because we all actually only observe it in the high excreting patients. There's no low excreter that is reported to to have developed a subdural hematoma. So this is very, very important. So if you have a patient with an isolated hematoma, it is not suggestive to be caused by GA1, but still a lot of these patients are actually analyzed for GA1. And this resulted in two recommendations. The first is that children with subdural hematoma and in combination with these characteristic abnormalities, you should screen or you should investigate for GA1. And the second is, have a GA1 patient and he suffered from a minor head trauma, then observe this patient closely, ideally impatiently for at least 24 hours to check for further complications. So that's on diagnostic, and I gotta change the treatment. The therapeutic principle in GA1 is still the same. It has been developed since many decades now, and actually the principle is easy. So we would like to decrease the amount of accumulation of GA and 3-hydroxy-GA because they are the known neurotoxic metabolites in the disease. And we try to achieve this aim with lowering the lysin intake. So lowering the lysin intake will end up in reduced lysin oxidation within the brain and reduced accumulation. And you can see that this is working very nicely. This is data from the mouse model. And in the brain and the liver, you see, depending on the reduction of lysin, you end up in a reduction of the accumulation of GA concentrations. But you also see you cannot give zero lysin. Lysin is an essential amino acid. It is important for the body to maintain growth and development. So if you give too low lysin, then you end up in malnutrition, in growth failure, and that's not what we want to achieve. So that's the theoretical background. And just an overview on the development of the dietary recommendations. You can see here that dietary treatment in the very beginning, highlighted in blue, the grade of recommendation was quite low. So there was many questions on the efficacy, how does it work, does it really help the children or not? And you can see that during the years we were able to improve this evidence and the strengths of the recommendation continuously, and now we have a grade A recommendation since the last two revisions already for dietary treatment. And for emergency treatment, there already had been a grade C, and now we have also a very strong level of recommendation now. So let's go into details on the maintenance treatment. So this should always be supervised by someone who is specialized in metabolic medicine, such as a metabolic center. And the basic principle is a low lysin diet with the supplementation of a lysin-free, tryptophan-reduced, arginine-enriched amino acid supplement in all patients up to the age of 6 years. So that's the basic dietary treatment, and it's accompanied by a carnitine supplementation to enable detoxification and to refill the empty carnitine levels in the body. You can also see here that this treatment is strictly calculated on the lysin intake up to the age of 6 years. So up to the age of 6 years, we really calculate the lysin intake. We calculate the intake of amino acid mixture, of energy, of carnitine. And then at the age of 6 years, there's a liberalization of treatment. And I'm going to show you why this is the case. But first I would like to show you some details, practical details about the first years. So this is actually how the diet looks like in the first years. So in an infant just born in the first months, we use breast milk or baby formula. So we want the mothers to continue to use breast milk if possible. We combine it with the lysin-free tryptophan-reduced special formula. Special formula in this age also contains fats and carbohydrates. And then once solid food is more and more implemented into the nutrition of the child, then we additionally use low lysin foods. Some are listed here. And then these foods are combined with the lysin-free tryptophan-reduced arginine-enriched amino acid supplements, which then only contains amino acids at that time. So that's the dietary treatment within the first year. And after the first year of life, of course, the variety of food is growing extensively, and then we have very, very different food groups, but mostly we try to use low lysin and lysin-free food in that age, but still we have also like an intermediate medium lysin containing food group that we also need, and you can see an example plan here, and this medium lysin content group is highlighted in yellow here, and you see that some of the items that you see in the plan are highlighted in this yellow color. I want to say something about the arginine supplementation. It was mentioned before and is still the frequently asked question, what shall we do about the arginine supplementation? So the background of it is that arginine and lysin, they both use the same transporter at the blood-brain barrier. So the idea is if you give arginine, you will lower the lysin influx into the brain, and thus you lower the concentration of GA and 3-hydroxy-GA, which is the idea. This is actually working. You can show this very nicely in the mouse model on the left-hand side. So you can see there is an effect that you can achieve with arginine supplementation regarding GA reduction, but you see that you need very, very, very high dosages of arginine. So these are actually dosages on a supra-physiological level that you actually need to achieve an additional biochemical effect, so additionally to the lysin reduction that you have already used. This is very important to stress. On the other side, in terms of clinical studies, we had examined two different groups of children receiving different amounts of arginine, and we were asking, is there a difference in their development, in their neurological presentation, depending on the amount of arginine that they were actually receiving within the first years of life? And the answer was no, there's no difference. So the amount that both groups received was fine and associated with a very, very beneficial outcome in both groups. So that showed us that even we don't know the exact amount that the GA1 patient needs of arginine, we know that the amount of arginine that he receives via the natural protein that he's receiving, via the amino acid that he's receiving, and also via the urea cycle, which is still active and it's producing arginine all the time. All these factors, they seem to be sufficient in terms of arginine and are associated with a good outcome. This led to a new recommendation that actually an additional oral supplementation of L-arginine, as you know from urea cycle defect patients, is not necessary for a GA1 patient. So the next question was, why or how does the diet change at the age of 6 years? And I was already telling you that at the age of 6 we are able to liberalize the treatment. But why or how is this situation actually being practiced worldwide? And earlier this year I attended the SSIM Dietitians Academy, and they asked, on the left-hand side you can see, they asked the question to all the dietitians, do you liberalize the diet? And you see that you have a very heterogeneous pattern of answers. So some do it, some don't do it, some depended on the clinical manifestation. And there was also a paper some years ago on the right-hand side, and it actually came to very similar results. So obviously there's still a lot of questions about it. And I try to show you the reasons why we should still reduce the lysin intake, but on the other side, why we obviously are able to reduce or to liberalize the lysin restriction. So let's start with the first question. Why should we continue to reduce the lysin intake in this age group? So this is a group of patients, 8 patients that we collected with a late diagnosed GA1. So every one of them is not found in newborn screening, but diagnosed clinically. And you see in the blue box is the clinical description, and we also included 2 men in their 60s and 70s, and they were the ones with the most severe neurological phenotype compared to patients younger than this age group. So this might show that there is actually a neurologic deterioration that these patients suffer during their life and end up in more severe symptoms in the older patients. However, of course, this is a very small group, so these results need to be interpreted with caution, of course. Second, we observe if we use innovative new neuroradiological methods, we can see that high excretors primarily, they tend to show higher concentrations of GA and 3-hydroxy-GA, going on and on with growing age, that we can actually detect in vivo by MR spectroscopy. And accompanying with this phenomenon, we also observe an increased frequency of white matter abnormalities. So that's something that we could clearly see, and this is also going on after the age of 6 years, so exactly in this age where this dietary adaptation is taking place. I have been talking about the extrastriatal abnormalities already, and on the left-hand side you see again the image on white matter abnormalities on the subependymal nodules. And also, if you put everything together, the image in the middle shows you that the high excretors clearly show increased frequency of white matter abnormalities. And also, there have been 3 reports of malignant brain tumors actually. All of them high excretors. None of them received guideline-accorded treatment. This is very, very important to stress. And we also do not know if there was a kind of a progression from subependymal nodules, for example, to the malignant brain tumors, because in most of these tumor patients there have been no previous MRI images available. So it's very, very unclear actually what these subependymal nodules actually are. But this led to a new recommendation, a recommendation to screen for these extrastriatal abnormalities in order to detect them, to have a basic result, and then to follow it up depending on the results every 2 to 5 years. However, the clinical impact of this recommendation is completely unknown. We do not know if we can save a patient or put him earlier to treatment if we do this method. So you see on the left-hand side, this is an open recommendation for research. Another phenomenon that we observed or just about to analyze is the peripheral neuropathy. So there have been 2 case reports in the literature of adult patients with a polyneuropathy with GA1. And recently we studied 21 patients and we did an MRI scan of them together with an MR neurography of the sciatic nerve of the lower extremities. And what we could see on the right hand side, you see the healthy controls and how the sciatic nerve should look like if there is no abnormality. And then on the left, just beside that, you see how the morphological integrity is destructed in a high excreting patient. We also did it with low excretors, and in low excretors we see much less, and in many times even completely normal results. We're just about to correlate this with functional measures, so we did neurography in all of these patients, and we hopefully are able to come up with a publication very soon. Another phenomenon that has been described outside of the CNS is the renal manifestation. So GA1 is called a cerebral organic aciduria because over decades it was only known that the brain is damaged by the disease, but there may also be a renal manifestation, a renal phenotype. Already almost 10 years ago, the EIMD registry, which collects organic aciduria patients worldwide, it showed that there is an increased frequency of GA1 patients with kidney failure. It's not comparable to other organic acidurias that hit the kidneys, MMA for example, but it was an obvious result. And we looked into this in our newborn screening cohort some years ago, and we could also detect a decline in kidney function in patients detected by newborn screening under treatment with no differences between the high and the low excretors. And this was not resulting in any patient in the necessity of doing dialysis or something. So there's still a lot of questions regarding this renal manifestation. So I showed you a lot of reasons to continue lysin reduction, because there obviously is something going on even after the age of 6 years. But on the other side, why are we able to liberalize the protocol? So the first is that the acute encephalopathic crisis, if you remember the image from the very first slide, is mainly manifesting within the first 2 years, some until 3, and only in single cases afterwards. There's no report on any crisis after the age of 6 years, and the same is valid for the insidious onset. However, the insidious onset, this is the next slide, these patients may manifest a little bit later. So if you compare insidious onset to the acute encephalopathic crisis, you see insidious can range up to over 5 months of age until the clinical manifestation. It is important to stress that in some patients we first see the MRI changes, then later we see the dystonic movement disorder clinically as a symptom. The second important point is that all these abnormalities that I showed you outside of the striatum, so the extrastriatal abnormalities, the kidney abnormalities, we just don't know what is the clinical relevance for the patient. Is it something that we only see in MRIs and we can measure it when we analyze blood or urine, or is it something that is really valid for the patient and important for his daily life and resulting in a pathology that it's really important to treat them? We do not know. But what we know is we observe it in treated patients, so we are not able to prevent this from happening by our current metabolic treatment. And this is also valid for the cognitive development. Just recently we looked into the cognitive development of early diagnosed GA1 patients, so all of them are newborn screening patients, and we tested them, we tested over 70 of them, and we could clearly see that the cognitive performance was a little bit lower than the general population if you take the whole group together. But you can see on the right hand side that the high excretors were about 1 standard deviation below the low excretors. But both groups showed a very stable development. But still, we needed supportive treatment in 1 of 3 newborn screening patients. And we were also not able to prevent this by metabolic treatment. So I summarize why should we, or I showed you in the last minutes why we actually should continue to limit the lysin intake, but on the other side we can use a liberalized dietary protocol. And this ended up here in the recommendation number 7 to use a so-called protein-controlled dietary protocol. And this is based on the safe levels for protein intake, and mainly it's based on using lysin-free and low lysin-containing food and avoiding lysin-rich food. And you maybe remember this traffic light systems you have seen in one of the presentations before. And we also adapted this for the GA1 protein-controlled diet after the age of 6 years. So on the left-hand side you see food that is not containing lysin or very, very low amounts. You can use this food without any limitation. And in the middle we have an intermittent medium group where the lysin content is higher, but we need this group in order to maintain sufficient protein, vitamin and micronutrient intake in the patient, and especially vitamin B12, iron and everything. And then we have completely unsuitable food that you see on the right hand side, which is high in lysin. So for example, nuts, seeds above 800 milligram lysin per 100 gram of protein. So this is the same, just a little bit more into detail. So we have formulated very specific recommendations, what amounts of animal rich and animal food products are you actually are able to use in the different age groups, also for adult patients. And again, we need a small amount of this group to maintain the intake of energy, micronutrients and vitamins in this age group. And if you do so, you will not need an amino acid supplement after the age of 6 years. We also have example dietary plans for this. So if you want to look this up, we have translated the parental guide in different languages. It is very practical, so the main focus on this guide is actually to describe the diet and all the practical aspects, but there's also a theoretical background on GL1. Unfortunately, it's not translated to Greek, but this is something that we definitely should consider. But I learned that so many people here speak perfect English, so maybe you can also use the English version. And it's free. You can just visit the guideline homepage and you can just download it as a PDF. In terms of emergency treatment, just very quickly, because actually there has nothing been changed compared to the previous guideline revisions. Before the age of 6 years, it is strongly recommended to perform emergency treatment in any period or any situation that is supposed to induce catabolism, febrile reaction, surgery, any period of vomiting, diarrhea in the child. After the age of 6 years, it is unclear what is the efficacy, but still we recommend to administer it liberally, because we cannot exclude that there may be a cerebral damage that we are not able to directly prove in the child. So just a little bit about the effects of treatment. I'm going to show you some of our experience of our newborn screening cohort. So we follow our newborn screening patients over 25 years now, and we were actually able to include almost all of them in our prospective follow-up study. And we identified 87 patients back in that day. And I already told you that we have quite a number of patients with acute encephalitic crisis and also the insidious onset, although they have been screened. But on the other side, the good news is that 2/3 of the patients remain asymptomatic, which is a good result, I think. But you can also see that we do not find all the low excretors, so some of them are missed by newborn screening. The next thing that we asked ourselves, what is the most important factor that decide on which group you end up with? And we found that the main factor, prognostic factor in GL1 is not a biomarker or something, it is the treatment quality. So I'm just quickly gonna guide you through this image. You see the most important statistical factors that are able to divide your population in two groups. And the strongest statistical factor comes to the top, and the following ones then below. And you see that adherence to emergency treatment is the most important factor. You have a yes here, and then also you adhere to maintenance treatment, you are on the very right-handed box, and the probability that you have an asymptomatic disease course is extremely high, extremely high. On the other side, if you do not adhere to emergency treatment, you will end up always in the very left box. So you will definitely suffer from a movement disorder, which is mainly a severe movement disorder. And then the maintenance treatment, non-adherence is also a risk factor, but not for the crisis, but for this insidious, slowly progressive striatal injury. So you have an increased risk for that if you don't have adherence to maintenance treatment. But still, you see there is a lot of room of improvement. We had many patients not being treated according to the recommendations, although actually they were formulated. So there's definitely room for improvement. Also in other cohorts, they have very similar observations, very similar results. This is the US cohort, it's the largest cohort that is known worldwide of GL1, followed after newborn screening. And you can clearly see those patients with newborn screening and then treated with the low lysin diet, they have by far the best outcome. If you use a low protein diet, so you don't calculate the lysin but only the protein, you end up in a much higher frequency of insidious onset. And of course, the poorest outcome you see in the targeted screening population. And we made very similar observations in a meta-analysis, so we were collecting all the evidence that is available into one meta-analysis. We are including over 600 patients, and we also see on the left side that newborn screening dramatically reduces neurologic phenotype and the frequency of movement disorder, but also on the right-hand side, if you are treated not with a low lysin diet but any other forms of dietary treatment, you have an increased risk for insidious onset dystonia. So best outcome, again, newborn screening in combination with the guideline according treatment. So that's, I think, a very important information. Newborn screening is not everything. It is very important what happens afterwards. In terms of safety of treatment, it's also something that we looked for. First, the anthropometric development. So you see that actually all patients, except the very severely dystonic patients, show quite a good and age-according development of body length and weight, which is very promising, of course. But the really severely affected patients, they do show growth disturbances. So once again, this highlights the importance of emergency treatment in these patients, and it is also very important in this analysis, none of the patients developed any major or minor motor symptoms after the age of 6 years. So let me just show you some new data. It's not published yet, it's an analysis that we are just about to finalize. We looked at the laboratory long-term outcome, and we found that actually on the right-hand side, you can see it, we have a very, very safe profile of all the basic laboratory and also the amino acid profiles with just very minor changes and values outside of the reference ranges without any clinical relevance, so that was a very promising result. We see age-depending effects, so you can, for example, see on the very left-hand side the lysin concentration is increasing a little bit because we liberalize the lysin restriction, so this is a treatment effect. You can also see on the right low box that the free carnitine is decreasing a little bit because we use less dosages. An interesting observation was also the glycine. Glycine is increasing with time, so we still have to think about what this actually means. And very importantly, we did not find any influence of the biochemical subtype or the clinical subtype in terms of this. So it actually shows that the outcome is the laboratory outcome is a safe development. So I tried to summarize everything that I just was telling you about treatment in a kind of a treatment pyramid upside down. So I listed this pyramid according to the strength of the level of recommendation. So the most important thing is the emergency treatment beyond the age of 6 years. It's followed by the maintenance treatment beyond 6 years, then the carnitine supplementation and the protein-controlled diet, both having a grade B recommendation. And then we have open for research recommendations, the emergency treatment after the age of 6 years, and also the carnitine supplementation. So just quickly, the last part. I don't want to go into detail regarding the overview on clinical monitoring, but it's important that a G1 patient is followed frequently, that he receives clinical investigation, laboratory investigation, and also assessment of development, of course. I have shown you some factors regarding MRI monitoring already, and we go into detail regarding the laboratory monitoring. So you see an overview here. So the most important things are actually the amino acids and the carnitine. So this is recommended really to perform regularly. And also the kidney function, which I'll show you in a second. And you also see that based on the results that we have so far, the basic laboratory is something that you actually only need in clinical situations that really make you think there is signs of malnutrition or growth problem or any kind of problem that you want to check for, but you don't actually need it regularly. So you already know these images, and they ended up in this new recommendation. It has not been formulated before, but the kidney function should be assessed yearly starting from the age of 6 years. And in terms of metabolic laboratory monitoring, I just show you these three. So I already told you plasma amino acids and the free carnitine, it's 17 and recommendation number 18, they are the most important one. What you do not need to do is to screen for GA and 3-hydroxy-GA. You can do it for scientific reasons, but they don't have a clinical impact as far as we know now. So that's the last slide before the last slide, so to say. Just one word to transition. Transition concepts are very important. We started to develop them some years ago, not only for GA1, but for patients with rare diseases. And this is just a suggestion how it could work. It's in German, unfortunately. I was not able to find an English version of it, but you see that on the left-hand side, the blue boxes, they are actually what the pediatric doctors have to do. And on the right-hand side, you see what the adult medicine should do. So both sides have some specific task. Once the process for transition is initiated, we should start with it at the age of 14, 15. We really try to see patients together. So first of all, of course, you need internal medicine doctors who are interested in metabolic medicine. You need the local structures for it, of course. And then you have to try to bring both together, see patients together, document the epicrisis, so the whole disease course, summarize it for really to transfer your patients to the adult medicine. And then at the very end, after you have seen the patient together, the patient is then followed by the adult medical doctors only. We try to really use this time to bring the knowledge, to really raise up the key information for the patient. So really to ask the patient and the family, and we use questionnaires as indicated on the right-hand side. What do you know about your disease? What do you want to know about the disease? But also, important social factors like education, studying, university, driver license, everything that is important that we try to really address here. So I'm at the end. I would like to summarize. In the third revision of the guideline on GA1, we have implemented all the evidence that was available, and there was an increased evidence for the efficacy of newborn screening and treatment, and those two factors are the most important factors for GA1 in general. After the age of 6 years, lysin should still be restricted, but based on a liberalized protocol. This liberalization is safe. It does not result in a health risk for the patient. We've implemented new recommendations on arginine, on MRI monitoring, vaccinations and transitions, but still there's open questions, of course, on GA1. So how intense should the lysin restriction be in adult patients? What exactly is the indication for emergency treatment in adults? And I think one of the most important thing, all the manifestations that we find in the recent years outside of the striatum, how relevant are they for the patient, and can we at all modulate them with treatment? So I think that's a very important question, and that's really the end. I would like to thank the guideline group for this long process, but a very successful process. And I'd like to thank you for listening and to being here today. Thank you very much.
Thank you so much, Boy. It's a fascinating presentation, and the way you presented the levels of quality of evidence and your recommendations, really informative. We can take some questions in the hall. Παρακαλώ κάποιες ερωτήσεις τώρα μπορούμε. Και μετά φυσικά μπορούν να ακολουθήσουν και οι τοποθετήσεις και παρεμβάσεις των γονείων και ασθενών όταν επιστρέψουμε ξανά στον καθηγητή. We can take some questions now in the audience.
Boyd, again, a big thank you for having you here, for accepting our invitation, and we'll have you here with us today. And also, for those who don't know, thank you also for yesterday, because Dr. Boyd accepted our invitation to come and examine patients in Cyprus in cooperation with Dr. Olga in Makari Hospital of the the special agreement with the Ministry of Health. So it was a very nice experience. And thank you very much. And it's feedback that we received from almost all patients here. And a question for you. Okay, we discussed again and yesterday and some other times. I will, but I have some new question after seeing your presentation about the arginine gain. So, as you said, it's not recommended to take lysine supplementation. However, in case you do the amino acid, aminogram, yeah, and it shows that arginine level is lower than the limits in these cases. And you try with the normal diet to increase it, and it does not increase. And it's always on the low level. In this case, can you, or do you recommend to take some supplementation until it gets to an optimal level?
Well, if you remember the slide, there is actually no evidence that the arginine is systematically being lower after the time point where we do liberalization. Mm-hmm. So in fact, actually, the arginine levels, they remain very, very stable in up to adulthood. So obviously, the arginine intake is sufficient even after the time point of liberalization, because still, I mean, we increase the amount of protein intake after the age of 6. So we also increase arginine intake, and still there is the endogenous production of arginine in the urea cycle, and this obviously seems to be sufficient. There's also no sign of a clearly clinical deterioration that can somehow be modulated by arginine supplementation, for example. Of course, we have to say that the level of evidence is low. So there's exactly one study that evaluated different arginine receiving groups regarding their development. So there should be more studies on that, and maybe we come to another conclusion one day, but at the moment...
even in cases that you see some patients with low, you don't actually increase it in other way. You try with normal diet, I say.
Because we really rarely see patients with continuously low arginine levels. Okay. So they are usually within the normal ranges, before and after the age of 6 years.
Okay. Another question: what about the women patient, adult patients, women with that are going to become pregnant? Do you follow a similar protocol with PKU? Shall they again restrict their lysine intake at the time of being pregnant, or you follow a normal diet as they used to up to that time?
Very good question. It's very rare. So we only, in fact, had one. We were following one pregnancy of a G1 patient, but there is no evidence. I mean, the risk of the child to suffer from GA1 is low. And that's the one thing. The second thing is that there is no, the situation in GA1 is different to PKU. In PKU you have a high toxicity of phenylalanine for the fetus. And lysine, it's unclear, but there's no data on that this should actually be the case in GA1. So there's no need to do a specific nutritional intervention for the mother. So actually this pregnancy went completely without any special developments. the birth was normal and it was very unspectacular actually.
And the mom, if I can ask, was diagnosed with the newborn screening?
In that case, no. In that case, it was a female that was diagnosed after presenting with neurological symptoms. She was older, so she was born before newborn screening was implemented. So we implemented newborn screening in 2005 for the whole country. In 1999, only in single centers, but she was older than that, so she did not profit from newborn screening. Yes.
Thank you very much.
Thank you. Any other questions? Couple more questions.
Hello. Many thanks for today and for yesterday as well. It was a wonderful one-day clinic, more than one day, I think. And I meant to ask the same question with Marius because a dietitian friend of mine called me last night and told me that she has a pregnant GA1 lady and she's going to see her soon. She doesn't follow her, and she knew that we were going to be here today, and she told me, "Can you ask?" So I got my answer. My other question is, we know about the other glutaric organic aciduria guidelines and other guidelines from the metabolic field. We do have one publication and maybe one revision, but for Glutaric Aciduria Type I, we have the original publication and 3 revisions now. So this means that there's a lot of work going on with the Glutaric Aciduria patients, so we will probably have more revisions because of new data later on. It means that you're very meticulous with your patients and you record everything. Why is this group different than the other, or that the other groups simply do not have fallen behind and everybody should work as hard as you? What makes this disorder different from the other metabolic disorders?
Well, that's a big question. First of all, I think we were lucky that back in the days the right people were at the right places to really initiate the process. It was already, or even before my time when I started practicing medicine, that people in Heidelberg, but also at other centers in Europe, they tried to bring together all the knowledge, all the existing evidence to formulate a guideline. And that was actually in 2003 they were preparing the first drafts, and until they finally met or until they finally had the publication, it took 4 years. In 2007 they included a lot of colleagues from the UK, from the US. They had very, very long-lasting discussions. And I think this was, there were so many open questions regarding treatment efficacy, regarding dietary treatment, regarding emergency treatment, regarding newborn screening, and we had so many weak recommendations back in that time that there simply was the need to see how can we improve that. And then in parallel we had the implementation of newborn screening. We started following our patients, and then of course we also wanted to assess the development, and that was in parallel with the guideline process. So we had this process of much more scientific evidence, following the patient, understanding one national newborn screening cohort, and answering scientific questions, and this helped us to develop and to improve the guideline process. And there were so many studies, not only the studies from our center, but all over the world. There had been more and more studies on newborn screening in GA1, and just the evidence got better and better and better, and this helped from revision to revision. The other thing is that we also tried to develop this guideline in the National Consortium of Guideline Development in Germany. They collect all the guidelines for the whole medical field, not only pediatrics. And the validity, the time that your guideline is valid, is only 5 years. So after 5 years, you are forced to do another revision. You are forced to bring everyone back together and to revise the guideline and then bring out a new revised version. That's now, of course, also a reason why we still have to do it. And I told my guideline group it took 2 years now, and I will contact you in 3 years again, because then we have to prepare the next revision.
So, don't get me wrong. That's so you are meticulous and you're doing your job, and it's fine for us to have these guidelines and to be revised. It's just, it seems that it's only the Glutaric Aciduria 1 group that works so hard compared to the other groups and the other guidelines.
Well,
so congratulations again, and we will be expecting the next revision in 3 years. Is it right?
Hopefully, yes, hopefully. But I have to say also to the other diseases, for example, the urea cycle guideline, there's the first revision exactly. Then I heard that the cobalamin C deficiency guideline is about to be published soon, the revised version.
Yeah, but
exactly.
We're talking about no revision or one revision.
That's true.
That's the difference.
Yeah.
Okay, thank you very much.
Thank you.
Thank you. I think we proceed with the presentations from the patient. Then we can revert